I have the great pleasure of introducing a friend and colleague, Prof. Mei Yoke. I've known her for a little over 20 years, I think. So she is currently the Senior Consultant at Paediatric Hematology Oncology and the Chair of the KK Clinical Ethics Committee. She did her pediatric training here in Singapore and her subspecialty training in the UK in London. And during her time, she was head of the Paediatric Hematology Oncology Service, as well as started the Pediatric Palliative Service within KK, and it is now spread to around Singapore. So her talk today will be about precision medicine in pediatrics. Am I correct?
Thank you very much. And I'm glad you all managed to come early in the morning. So I know it's early in the morning, but I'd like you to imagine that you're not here in Singapore. You're not in Kentridge Guildhouse. You are in a world where birth is not left to chance. Parents are allowed to genetically tailor-make their baby so they can have the perfect baby that they want. And the identity is tied to the genetic makeup of the child. Okay? And because of that, there's segregation based on the genetic predictions of what the child was born with. But diseases are treated in a targeted and individualized fashion. So you have precise and personalized medicine. So I think some of you may recognize that the fictional world that I'm describing came from this 1997 movie, Gattaca. I wonder if anyone has watched the movie? Okay, so those of you who haven't, it's an excellent movie. I know it's old, and it was actually before its time. It was actually produced before the human genome was actually fully sequenced. So it's really prescient. So my talk today is on precision medicine, but let's start with some definitions of what we understand precision medicine to be. One definition is that it's a medical model that involves the customization of healthcare with medical decisions, treatments, practices, or products being tailored to a subgroup of patients, rather than what we are familiar with as a one-drug-fits-all model. So, you know, in medical school, we are always taught to lump cases together. This model actually is counter to what we are taught. We are supposed to split patients. So instead of lumpers, we are supposed to be splitters. The other word that's been used a lot is personalized medicine. It's often used interchangeably with precision medicine. But I think personalized medicine has an extra connotation that you have a unique medical product, including drugs, that is designed, created, and tailored for that one particular individual. So it's really like an N=1 concept. So I'm going to talk a bit about, I'm going to talk on precision medicine, but I'm going to base it on precision oncology. Not just because I'm an oncologist, but because precision medicine has really impacted the field of oncology the most. And that 90% of precision products that has been registered are actually oncology therapies. Okay. And although I'm going to talk, sorry, am I moving too much? No. Okay. I'm going to talk based mainly on genomics. But precision medicine is really more than just genomics. It really includes environment, the lifestyle, and the various other, what we call omics, right? Proteomics, metabolomics, you name it. And then finally, I'm going to come down to the actual meat of the talk, which is the ethical issues associated with precision oncology. So it really started 20 years ago. It's been 20 years since the human genome was fully mapped out. And because of this momentous event, precision oncology and precision medicine really took off. So I'm a clinician, so I also like to start with cases. So this is a sort of an illustrative case that I deal with every day. A 12-year-old girl with newly diagnosed acute B-cell lymphoblastic leukemia. She has hypodiploidy, CD20 positivity, BCR-ABL fusion gene positive, TPMT genetic score of 2, and the minimal residual disease markers at the immunoglobulin and the T-cell receptor gene rearrangements, is treated on the MASPOR, which is Malaysia and Singapore 2020 protocol, MRD guided with the addition of rituximab, which targets CD20, dasatinib, which targets BCR-ABL, and thiopurine doses adjusted down because of a TPMT genetic score of 2. Sounds like gobbledygook, right? This is the term that I hate to use is a COVID term. This is the new normal. This is the new normal for oncologists. Okay. Or you have another illustrative case, a 17-year-old boy with multiply relapsed undifferentiated carcinoma, previously treated with multiple causes of chemotherapy, surgery, radiotherapy, but he relapsed. So he had this relapsed tumor sequence, which identified a novel NTRK gene. This gene has not been described in sarcoma of his type. But there is a pan-TRK inhibitor called larotrectinib, which has not been registered for use in children. Neither is it registered for use in this indication. But it was used because it was there. And it produced short-lived response, but very quickly lost the response. And when the next generation TRK inhibitor was used, larotrectinib, there was no response at all. So what's the promise of precision oncology? We are now profiling all tumors, not all tumors, we are trying to profile tumors to identify targetable alterations so that we can actually, if there is a drug that's already there that can target these alterations, then you are actually specifically treating that the abnormal cell. Instead of the usual chemotherapy way, which I usually tell people it's like a blunderbuss, you just kind of use M16, you just fire anything. Basically, chemotherapy works by attacking cells that are rapidly dividing, of which cancer cells is one. But we have many other cells in our body that rapidly divides, and that's why you have side effects. So the promise of precision oncology is that you will have less side effects, and you have more efficacious tumor killing because it just targets that particular cell. An example is BCR-ABL targeting in leukemia by tyrosine kinase inhibitor like imatinib. Ultimately, what we want is we want to improve the outcome. But the premise of precision oncology is really based on the concept that somatic genetic mutations, meaning the mutations of the cells of the tumor, are the actual drivers of the cancer formation. Okay. And if that's the case, you might have a tumor that has that specific mutation, and so you can even change or refine the diagnosis. Instead of what we previously just looked under the microscope to see what this cell looks like, now you can actually drill down to actually what the gene is. But it's obviously a complex developmental process, and you remember Brian's talk yesterday, and all these complicated types of tests that you can use to detect all these genes, the depth of testing, the breadth of testing, the types of tissue you need to use. It is very complicated. It's even complicated for oncologists to understand. Okay, what more parents? So this is really where it started in, I think it's 2000 or 2001. That is when imatinib Gleevec has been FDA approved for the use in chronic myeloid leukemia. That's really the start in oncology of targeted therapy. But it's still not so specific. It's just anybody with CML, right? Then now you're going on to CAR T therapy, which is a little bit more specific. Some of you may recognize the little girl there. CAR T therapy actually changed her from a 7-year-old girl that was going to die to an 18-year-old girl now. She's probably cured of the leukemia, and she was actually told that she was going to die. And this is more specific because what CAR T therapy does is that you use the T cells of the patient, re-engineer it so that it recognizes the proteins in the patient's leukemia cells. So it's really specific. It's really meant for that particular patient or the type of leukemia that the patient has. You can even have an N=1 custom-made drug. This is a drug called Milasen, which was designed to treat this little girl called Mila Markovic, who has a fatal disease called Batten's disease. And scientists at Boston Children's Hospital found a mutation in Mila's cells, and they made a drug to block her particular gene mutation, and thus restoring its function. And so this drug is called Milasen. It can only be used for her, basically. It's really an N=1 drug. Other than treating the cancer, precision oncology also promises to prevent cancers from, or rather, something that you can do to prevent cancers from happening. I'm sure you'll recognize Angelina Jolie. And she found out that she has got BRCA1 inheritance, which made her, about like 80-90% more likely to get breast cancer like her mother before her. She decided she will just do a double mastectomy, and then she's not going to get breast cancer, right? So Not everyone is going to do something like that, but this is something that can be possible, if you have a predictive kind of result like that. But despite all these, advantages I've been telling you, why do we keep saying that it's a promise? Why isn't it standard therapy? After all, it's already 20 years since the genome has been sequenced, right? Why has it still remained a promise? Well, many reasons, some of which has been covered by Brian. There's been uncertainty of a lot of things about the implications of the abnormalities that we find. Is the abnormality really the one that is the driver of the oncogenesis? Or is it just an innocent bystander, it just happens to be there? Or is it a normal variant, right? And because how we sort of discover whether this is an abnormal aberration or not is by getting lots of information about the population that we are studying, okay, the normal population. So you have lots and lots of data, right? And all this data has to be analyzed, has to be interpreted. And this is a new field, it's a new expertise that even oncologists like me, end users like me, find it very difficult to understand. And there are safety and cost issues. When we assess new drugs, the gold standard is the randomized controlled trial, right? You compare, the drugs used on this population against what previously has been treated. But how do you test n equals to 1 drug? There's only one person it's for. How in the world do you design a trial to convince regulators that this drug is safe? Okay? And if you have to adjust sort of trials, do all sorts of fancy trials, it will cost pharmaceutical companies a lot, okay, to register a drug. Okay, it might make them sort of forget it. I'm just not going to register. It's not going to bring them money. And also incidental findings, which Brian has already covered. The wider you cast your net, the more that you're going to find unexpected findings that's not related to what you're looking for, which is a current cancer. Whether to tell or not to tell, Brian has already covered, so I won't go through that. And finally, pediatric cancers, as opposed to adult cancers, actually carry fewer somatic mutations. So that's why you find in the drug world, a lot of the targeted therapies are actually targeting mutations in adult cancers. Okay, a lot of times we use these drugs because we find the same kind of mutation in the child, but there's no guarantee that it's actually going to work the same way as it does adults. And sometimes we have what we call tumor agnostic kind of mutations, where you have a mutation in a different kind of tumor. Is it actually the same? Is it really the driver of that particular tumor? We don't know. And finally, you have far-reaching potential consequences, right? And insurance, I know a lot of people are worried about insurance. Family implications. Somatic mutations won't have so much family implications, but if you find a mutation in the germline, you are going to have family implications. Okay, and how accurate is this predictive mutation that you have found? And finally, you might have self-fulfilling prophecy, right? Somebody who has a mutation that is supposed to portend a poorer prognosis. The patients might decide, since it's poor, I'm not going to have any treatment. Okay, and is that right? And finally, we come to the raison d'etre of the talk, which is the ethical concerns, right? So what are the ethical concerns? We have the 4 principles: autonomy, beneficence, non-maleficence, and justice. Really, the adequacy of informed consent. What is the utility, the risks, and benefits of precision oncology? Justice, resource allocation, equity, access. And finally, the ethics of care. How does it affect human relationships and our interdependence? As I alluded to earlier, this is a very complicated field. I don't understand. So if I were to have information session with the parents, they're going to have a lot of information overload. Okay, it doesn't help that there's a poorer genetic health literacy in the public. Okay, not just in public, actually, even in healthcare professionals. And like what Calvin in one of my favorite comics, Calvin and Hobbes, says, the more you know, the more you realize you don't know. Or the more you realize there's lots of grays and lots of complexities. And if you're like Calvin, who decide, knowledge is paralyzing, forget it, I'm just going to shut off. You just tell me what to do. So you can imagine that informed consent isn't really informed after all. And finally, don't forget that the time when we have to talk to the parents about this is often the time when our backs are against the wall. Okay, traditional treatment, conventional treatment hasn't worked, and we are now talking about something that is experimental. So there is a lot of anxiety, there's a lot of worry, a lot of stress, And this is magnified if you are making a decision for somebody else. Okay, has been studied. This is called emotional overwhelm. If somebody has to make decision for themselves, they are already emotionally burdened. If they have to make decision for their child, it's magnified 1,000-fold. And finally, there are inherent biases in all that we say, all that we do. If you look at all the precision oncology studies, okay, they are called things like precise, inform, match. Even precision oncology itself is like precision oncology. It's such a positive term, right? Imagine if I were to tell the parent, I'd like you to, participate in this study called chaos, okay, or unknown. Do you think they're going to participate? Unlikely, right? And then finally, pro-innovation bias. A lot of scientists who are in this field obviously believe strongly in this, okay? And in a way, it happens to a lot of us. I mean, even if it's unintended. We tend to say, communicate in a way that will tend to bias them. This is called framing effect, right? Even though you don't intend to, we are supposed to be neutral, right? But how can we ever be neutral? Okay? If you are pro-innovation, you are going to deliver the information in the way that kind of persuade them to believe in what you believe in. And remember, I was telling you there's a time pressure. Okay, the child has relapsed. You can't really wait for you like 1 month, 2 months for you to make up your mind, right? The patients, the families are in a vulnerable state. It's very stressful. And like I said, it's difficult to impart knowledge garnered over many years of medical study for us, over a relatively short period of time when we're taking the consent. So in my opinion, I think true informed consent is practically impossible in precision oncology. It's only an ideal that we aspire to achieve, but it's problematic and it's difficult. That's the parents. What about the child? Okay. Dominic has already said, we allow the child to say yes, but we don't allow the child to say no. So what sort of consent is this? What sort of assent is this? So I won't belabor this point. And finally, I think Dr. Jinapa has talked about this, therapeutic misconception. As I said, these tests and these targeted therapy are really experimental, okay? But there is a blurring of line between clinical care and research. Parents often think that when we are talking to them about this, that we are talking about therapy that has been proven, which is not the case. And even if it is something that is has a lot of science, research really does not benefit the recruited participants. It's meant to garner data to benefit future patients, right? And it's often very difficult for parents to grasp this concept. There's also, even if they were to know that this concept, the goal of research is acknowledged, you can have parents who overestimate the benefits or underestimate the harms, and this is called therapeutic misestimation. This is different from therapeutic optimism, where if you tell somebody, you have a 1% chance of survival, they say, okay, my child is going to be that 1%, okay? It's just somebody who is very optimistic. But somebody who misestimates the therapeutic benefits will say that you tell me 1%, but actually I think it's more than that. I think it's probably 50%. So that's misestimation. And so if you have therapeutic misconception, therapeutic misestimation, you are going to invalidate informed consent, right? And then utility. The proof of value, especially in pediatric oncology, is very difficult, right? You need lots of data, you need lots of studies, randomized controlled trial, but there are none in children, right? So it's hard to sort of say, what is the real utility of precision oncology? How do you use it? When do you use it? Whether you use it or not is very contentious. It's different in different centers. And plus, a lot of papers that you read will say, there's a good response and all that, but you don't know that sometimes half a year later, you have development of resistance, you have antigen escape, you have selection pressure from prior therapy. So it's not as simple as what we like to think, right? And if you don't sort of prove utility, it's very hard for you to get funding from your governments. So of course, we all like to think that all the drugs that we use are at level 1. They are recognized. There's a recognized biomarker. It's predictive of response. There's an FDA-approved drug in this particular indication. But in essence, in truth, it's a whole range, and you can even go down right to the bottom where you only have biological evidence. That's about it. And finally, in our current world where you have value-based reimbursement system, utility is defined not just by outcome, but by cost. And again, as I said, it's really difficult to sort of analyze, do randomized controlled trials and all that. So, sorry, it's too early in the morning. So just as precision medicine is personalized, cost-benefit calculations will have to be personalized as well. You have drugs that really do work, okay? There's a lot of data. It probably is cost-benefit. There's cost-benefit, especially if you have to look at what happens if the child is not treated and they get multiple causes of subsequent chemotherapy that costs more. But there are drugs that do not have that kind of data. So how do you have a blanket sort of rule to say that precision oncology is has cost-benefit, a good cost-benefit ratio? And then coming to justice, these drugs are eye-wateringly expensive. Okay, Kymriah, which is a commercial CAR-T product, costs $500,000 US. But it's not as much as Zinteglo, okay, which is a gene therapy drug for beta thalassemia, which is very common in our part of the world, and it costs nearly $3 million US. Which government will spend $3 million US on that one particular patient? Okay, and is it ethical to spend all that money on just one patient when that $3 million could be used to vaccinate, the population, to have good sort of programs for nutritional deficiencies. So health systems often have other fires to fight. And then finally, equity and access. Even if the government has money, right, there is a problem accessing all these drugs, okay? A lot of them are mainly available in tertiary or quaternary centers, and mainly in developed countries, whether they use it in clinical trials, off-label use, or compassionate access. In pediatric oncology, it's even worse. Okay, all these drugs are often meant for use for adults. They are registered for adult use. Very seldom are they registered for pediatric use. Okay, so, and if you have lack of real world or research data, you're not going to find a government willing to reimburse the cost. What about societal and legal implications? Brian has talked about the privacy issues and then liability as well. There's going to be discrimination, right? Is genetics going to be the new race? Okay, instead of saying that, you discriminate against somebody on basis of the color, are you going to discriminate somebody based on the fact that you have a gene that makes you more likely to get breast cancer? And it might exacerbate, and it will probably exacerbate existing healthcare disparities. Remember, I was saying that all these, how do you tell whether the abnormality that you found is abnormal? It's because you're comparing it based on what you think is the normal population genetic varieties, right? A lot of these populations that are studied are not diverse enough. They are mainly from the West. They are mainly from Caucasian, European descent. Okay, you're not going to get like population studies on people who are African, people who are Asian. So, is the abnormality that you find really, really abnormal? Because you're comparing it on another population. And if you are going to use based on this kind of data, you're just going to exacerbate the healthcare disparities that are already existing. And finally, the ethics of care. Regardless of what we say, progress is going on. Okay, and this relentless march is going to risk leaving some, especially the vulnerable, behind. And you are risking reducing humans to mere collection of genes. Okay. And finally, like what I was saying, you're going to affect the relationship between the patient and the doctor. Okay, he's going to look at data, he's going to look at your genes, he's not going to look at you. Okay, he's not going to consider you as much as if he hadn't had all this data in front of him. But like I said, regardless of whatever is happening, it's already happening in the world, right? You have all of us in America. You have the 100K Genomes Project that's in the UK. In Singapore, you have the SG 100K project. And you have lots of organizations that's already started, like Precise. So I've only talked about precision oncology, but precision medicine itself has lots of other sort of promising uses in pharmacogenomics, in the rare diseases realm. In health systems, it's supposed to reduce waste, or rather it promises to reduce waste, improve outcomes, give you better value for money, and overall health of population is supposed to improve. and even the preventive medicine, as I was telling you about. So coming back to Gattaca, I mean, those of you who haven't seen it, sorry, this is going to be a spoiler alert. So the basis of the movie is really, people are discriminated based on their genes, right? And so you have the protagonist, the hero, which is Ethan Hawke, and he was dealt a bad genetic hand. He was born with, I can't remember, I think 80% chance of having a fatal heart disease, and all bad, basically, it's just bad. And so because of that, he was put as a cleaner. Okay, he was not allowed to achieve his dream of being an astronaut. Okay, but because he really wanted to, he did some sort of subterfuge with the other sort of a person who was given a good genetic hand. He was supposed to be like the best athlete, the clever person and all that. But unfortunately, he had an accident and he became a paraplegic. So he was unable to fulfill the genetic promise that he was given. And so, I won't sort of, long story short, ultimately Ethan Hawke triumphs, right? And so it comes to this tagline that there's no gene for human spirit. Okay, despite all this genetic, how many percent you're going to get this and all that, there's no gene for human spirit. And basically that's the message. So in conclusion, precision medicine really holds great promise, okay, to improve the health outcomes of our population. But the ethical issues need to be recognized and addressed before it can be implemented and integrated into mainstream care in a responsible manner. And to be successful, I feel precision medicine shouldn't really be in the realm of the scientists and the doctors and all that. It really should be patient-centric, and patients and communities should be equal partners. It shouldn't be, I tell you that this is the information, do you want it or not? Okay. And we need more real-world data, and we need to collaborate. More global collaborations are necessary so that we can prevent the development of a Gattaca-like world. Actually, if you think about it, precision medicine isn't really a new concept. In the past, we have always been told, you must treat the patient, you mustn't treat the disease, right? And this is an adage that's been since, Hippocrates' time and all that. So now, instead of saying, treat the patient, don't treat the disease, we should say, treat the patient, don't just treat the genes. Okay. So that's all I have. Thank you for your attention.
Okay, we have a couple of, 15 minutes actually. Anybody have any questions for Mei Yoke? Thanks, Mei Yoke. It's a wonderful talk.
I might use Brian's method of giving long answers so that I don't get so many questions.
She can ramble, I just warn you. Anyone?
Thank you, Mei Yoke, for simplifying precision medicine for me. You mentioned that the issue about the promise not being able to be fulfilled. And it appeared to me that other than the costs, and leaving aside the issue of costs, it appears that the ethical issues seem to primarily arise because of lack of certain data. Is that one major source of the ethical issues? If that is so, may I ask, in Singapore, how must the research regulatory framework change or accommodate to be able to include conditions like these, where you only have 2 or 3 cases? Because once you get the data, then you can. So what do you think has to change? Because if you don't change, 10 years from now, somebody else will be saying the promise. What can we do now? Thank you.
I think some things are already being done. I think, the traditional way of doing research has to change. We have outcomes, and our outcomes are usually either death or cure from the condition. We will have to find surrogate outcomes, different kind of outcomes. We may have to use real-world data. A lot of these drugs are used in a compassionate basis. Okay, so they are not necessarily in a trial, but that's not to say that the data that we get out of treating n equals to 1 patients can't be used. we can collect all these data, and these are real-world data. So it's not going to be easy, especially in the regulatory realm, because the regulators, or the people like HSA, FDA, and all that, they're used to the traditional way of getting lots of cases, lots of data to prove concept. But it's not going to happen in precision oncology, right? You're going to have drugs that are meant for a small group of patients, okay? And they will just have to, it has to be a mindset change. Okay? So I'm not sure whether there's other ways. I don't know, maybe Brian might be able to tell. Like I said, this is a very complicated field. And I think the more you find out, the more you realize that what you originally thought is this concept is actually different. Okay? So I think we have to be nimble, we have to change, and we just have to change the mindset and do sort of research in a non-traditional way.
Yeah, thanks very much. So I've been teaching ethics of genetics since Gattaca came out, and I find it one of the most irritating films I've seen. So it's a story about the bad use of genetics that's used to object to all forms of genetics. And there's no doubt that you can increase natural biological disadvantage by using genetic knowledge, but you can also reduce it. So if you target the worst off and target treatments to them, you can reduce natural genetic disadvantage. So it's really up to us. And this kind of slogan that there's no gene for the human spirit, that's just false. The human spirit is at least 50% genetic. So we all differ in our level of determination, ambition. Behavioural genetics has shown that all features about ourselves that matter have a significant genetic contribution. So it's anyway, I just have to kind of react to that. But my serious question is, I often hear this. There's great, bias in our genetic samples, and there aren't any African samples. Now, Singapore is targeting its population, Chinese, Malay, Indian, and that's how the world is. We either are a drug company aiming to make money out of a particular population, or we're a government serving our citizens. Are you seriously suggesting that Singapore should be investing in developing an African sample for the sake of global equality, or do you think it's okay to focus on your population?
No, I mean, I think it's in response to all the previous sort of data we have that populations are now doing their own sort of genetic genotyping. All the aberrations that we find on the, say, oncology, for example, are compared to data sets like things like ClinVar and all that. And these are populations that are not our populations, but that's the only data set that we have at this point in time. So in the future, if like SG100K and African countries doing their own and all that, if you really want to apply precision medicine properly, you should be comparing it against data of your population. But at this point in time, we don't have that data. I mean, SG100K is only just started. And even if you have the 100K, is that big enough, to have a phenotype of your population? At this point in time, we are still comparing it to data sets that are traditionally Caucasian and white. We don't have any better solutions now.
Hello, morning. Thank you for a wonderful lecture. I have two questions. One question is, how do we reduce the cost of this very expensive treatment, especially for conditions like, let's say, cystic fibrosis? Now we have very good drugs available for, like Trikaftor for the Delta 508 mutation, which is common in our populations. Now, how do we reduce the cost of this? I think there was a public protest in a country, in Argentina, for the high price of Trikaftor for personalized medicine. That is one. I think there should be some kind of movement towards that. And second issue is that, are we going to look at genetic testing for common disorders? Like, for example, we know that pediatric asthma is a very varied disease, and their response to medication is very different. Whereas a small percentage may respond to Montelukast, the other may respond to let's say a corticosteroid, or a third may respond to a tiotropium. So now the issue is that are we going to look at genetic testing for common disorders? Maybe asthma, maybe diabetes.
So, I mean, the cost issue, I'm not sure I have a good solution for that, really. I mean, the drug companies, they don't just put that tagline just to shock us. There is a lot of cost involved in them producing this particular drug. And they know that the market is small, right? I mean, the reason how drug companies could lower the price is if you sell that drug to many people, that will recover the cost of them producing the drug. But in this kind of precision medicine kind of drug, you know that the market is small. The amount of money you use to produce and manufacture and all your R&D and all that is a lot more than all these previous drugs. So I do kind of understand why they have to charge so much. I mean, one way of sort of reducing the cost, in a way, I'm not sure it's reducing. Say, for example, CAR T therapy. The commercial CAR T is $500,000. If the population is willing to invest, if you were to have our own CAR T making facility, which is what's happening in Singapore, you can actually manufacture the cost of CAR T at 1/10 of the cost. Okay, but that would mean that the government will have to invest, in structures and all that, and they have to spend money that way. So it's not going to be, it's not a zero-sum game. So I'm not sure I have a good answer to that. And then, okay, so common drugs, common conditions. So, the reason why it works so well in things like oncology and all that is because you have not so many genes that affect the condition, okay, the driver. You may have, like in oncology, it tends, in pediatric oncology, it tends to be 1 or 2 kind of mutations that we think cause the disease. In things like diabetes, asthma, it's going to be polygenic. You have plenty of genes that may have an effect, and each gene, the effect is very low. It might be, I don't know, a few % of causing the disease. How are you going to target? Which one are you going to target? So that's going to be difficult. I don't know whether Brian might be a better place to answer this. This kind of polygenic disease is difficult to generate specific targeted drugs for them.
Prof. Daniel?
Yes. Thank you, Mei Yoke, for your very illuminating talks. I also like the movie a lot and use it for teaching genetic ethics for a long time. But for your last comment, could it be possible that we can really discover human spirit gene in someday? Yeah, because for example, in my review, some personality trait, very persevere, optimistic. This is probably in our gene. Okay, so if that is this level of spirit, it could be discovered. But if we are talking to another level of spirit, like a spiritual care at the end of life, that might be different. So this is first question. And the second question is quite a challenging issue of this expensive gene therapy treatment. And we are currently facing this difficult policy decision. But the government, or the National Health Insurance, just agreed to pay for the SMA gene therapy. It will be 1.5 million US dollar, but okay. Now that they decide, okay, this is effective, and once for lifetime, then they decide to pay for that. But then there will be challenging issue follows. Okay? You have other kind of treatment for rare disease, equally expensive, and then do you have any policy how to make such difficult choices in your treatment insurance plan?
Oh gosh. I mean, this thing about other genes being found for like human spirit, I agree, you might have that. But inheriting the gene doesn't mean that you're going to fulfill the promise. You may not fulfill the potential of what the gene gives you, right? A lot depends on, and that's what precision medicine is about. It's not just the genes, it's also your environment. It's also your lifestyle, which is what happened in Gattaca, right? He was given that bad hand of genes. But because of either maybe he also inherited genes for good spirit and all that, but it's also his environment, right? It's also his maybe the way his mother brings him up or whatever. So I think you cannot discount that. You may inherit the gene for being optimistic, but if you are raised in a family that keeps on putting you down, you are not given a lot of opportunities, it might affect you. As to the cost, I really don't. And I think, I feel there's a problem with paying for expensive drugs like that because we still don't know a lot. For example, the SMA gene therapy. It's not true that it's a one-off use. There has been cases where the use, the effect has lost, and they might have to give another dose. So, are you sure you're only spending 1.5 million? You might be spending more. Okay, so it's really difficult for health systems to calculate something like that. I guess we need more data. I mean, I'm not sure how we can be equal. And I think, ultimately, it really depends on whether you are a deontologist or whether you're a utilitarian. Are you going to benefit many, or are you going to benefit somebody just because it's right?
Hi, thanks, Mei Yoke. Thanks for this talk. So I'm from Malaysia, where resources is very limited, but we are close enough to Singapore where CAR T-cell therapy is available. So we have parents who then, cross the causeway for this promise of CAR T. They sell their house and they come back really poor without a child. How do you navigate this? Because we can't stop them from going over, but how do we ethically tell them that this is not the promise? It's really sad that it's so expensive and they come back poor, and then you have their siblings asking, do you have enough for my university? That's what one sibling said in our family. How do you negotiate all that?
It's difficult. I mean, and that's what I was saying about this pro-innovation bias and all that, and the fact that they really don't understand exactly what the whole thing is about. I think small little things that we can do. I mean, we have to make sure that the information is distilled down to understandable small bite size. And that may not just be talking to the parent. We have to give them information to read pamphlets. Give them some time off. I mean, even the presidential election, we give them a cooling day, right? There should be a cooling day for these kind of things, not just, oh, your child is relapsed now. I want you to decide now, do you want to have CAR T or not? A lot of parents felt pressured by time, and by the fact that they don't really kind of understand. I mean, this is sort of to really make sure that they are truly informed as much as we can. And finally, I have seen physicians give sort of taking consent to parents, and they really, really believe in what they are doing, right? And the way they speak, I can hear that, if I'm a parent, I will be really persuaded. And I don't blame them. I mean, they really, really believe in what they are doing. So I don't know whether it would help if you were to have sort of like a third party, somebody who is maybe somebody from the ethics committee to sit there and to make sure that that we give them a neutral a stance as we can. But at the end of the day, if that's what the parents themselves choose, this is their choice, right? As long as they have all the information, they understand that this is experimental, they understand that one of the options is that, the child is going to be gone and you're going to lose how many millions of dollars.
One of the challenges we've highlighted already is uncertainty, and one of the difficulties is that we keep finding new information that we haven't looked for before. So then we don't know what it means, and then we do different things. So then you can't tell what would have happened if we hadn't done the things that we've done, whether giving these drugs. So how much could we, if we wish to, solve some of that problem by looking back at our historical cohorts and saved samples and looking, for example, at those treated a decade ago with leukemia, at what the genetic profiles were at different points in time, and looking at, do we have those samples, and can we go back to gain that? That I can see there's a great desire to test those in front of us now, but that becomes very difficult to interpret because we lack that historical data. So can we do that to solve that uncertainty problem?
I think there are some groups that do have historical tissue data, or rather historical tissue that's kept. But as to whether these tissue are good enough to get the information that we want, I'm not a geneticist, and I don't really know the technical details of it. But you need good enough tissue to be able to test. And plus, all these genetic changes change. Okay, you might have a particular genetic change at diagnosis, and when you relapse, it changes. Okay, so it is not a fixed thing. So I'm sure the answer to all these is to get more data, But I'm not sure whether looking backwards would help you looking forward. I think ultimately we're going to have to have sort of international tissue bank, that kind of thing. I mean, currently, because of privacy issues and because of, territorial issues, we have tissue banks that are particular to countries, particular to institutions, and they're all small numbers. Why can't we sort of collaborate and have big numbers, right? The more numbers you have, the more robust your data, basically.
Sorry, we have one last question, and then you can then attack me outside at tea. It's fine.
Sorry, Mei, to keep you on the podium. My question is about research and clinical practice. You meant that the practice is an N1 experiment, but you are talking about the precision medicine is like a research with a large group scale. So there is some difference between, when we say precision medicine is research and clinical practice is closely related, but in reality, sometimes we're doing research by the name of precision medicine to gather all the population base and just for like the estimation, some general knowledge. And then we are saying this is precision medicine to apply the knowledge into this single patient. So in this translation, there may be some misunderstanding or some confusion from the patient side. So some participant or parents join or consent to the research because they are joining the joint venture of knowing the disease for their children. But sometimes they are just doing for their altruistic motivation. So how can we differentiate, or do we need to differentiate these two types of motivation, or do we need to separate these two things to communicate more clearly to the public?
I mean, I think I'm not sure the benefit of differentiating, but I think we really need the parents to know, especially with the precision sort of targeted drugs that we're offering now, that all these are experimental. It's still experimental, but I think because of the fact that it is used a lot in compassionate basis and all that, the blurring of line between clinical care and research is there. It's difficult for the parents to grasp, and even if they do, I think there's studies that they ask parents what is it that you hope out of precision oncology, and it is the hope that their child is going to be cured, when actually it's not. The whole premise of research is not to cure this particular child. It's a bonus if it is, but it's basically to generate data for the future child that is going to come with that condition. So I don't know whether that helps. Thank you very much.